Good afternoon. My name is M.K. Graham. Happy Wednesday to each of you, and on behalf of FADA, welcome to today's webinar entitled Best Practices in Screening for Adolescent Substance Use Risk, Tools of the Trade. This webinar is being made available through a collaboration of the Florida Department of Children and Families and FADA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to all panelists by using the chat panel. The button to open the panel is usually located at the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. But please note that we will be holding all questions until the end of today's presentation. Our audio is broadcast through the internet on your computer. If you are experiencing poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. For computer audio, click Communicate menu, then click the Audio Connection panel. Click Disconnect. Click Communicate menu and Audio Connection again. Then click Call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are posted in the chat panel. You must be connected to the audio of this presentation and also view it on screen to receive a statement of completion. We are unable to verify attendance if you are not connected to WebEx via your computer or mobile app. Therefore, call-in only attendees will not be eligible for a statement of completion or CEUs. The recording in today's materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, visit www.fada.org. Navigate to the Resource Center and click on the Training Library as shown on the screen. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of completion of webinars and workshops taken through FADA. Up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the evaluation is necessary to receive CE credits or access your statement of completion. Please note that the evaluation will close at the end of the day on Monday, December 16, 2024. At the end of today's webinar, you will have 3 opportunities to complete the evaluation. The first is a link that I will post in the chat. The second is a follow-up email from WebEx. And the third is an automatic web browser pop-up that will pop up when the webinar ends. To complete the evaluation, you will first need to register or sign into your account. Please make sure that your name and email address match the name and email that you used when you registered with WebEx. All information that you provide remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to the CE broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your license or certification number when you register on our website. If you need assistance with account registration, login information, or accessing the evaluation, you can fill out a contact form on our website or email training@floridabha.org before December 16th. Please note that WebEx monitors the arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of completion if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Statements of completion will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CE use will be reported to the CE broker within that same time frame. Please understand that this presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should also know that sessions are recorded and published on various media. And now I'm going to introduce our presenter. Adam Musielewicz has over 14 years of experience serving diverse communities in his home state of Colorado. Primarily under the umbrella of public health, Adam has occupied professional capacities in areas such as youth development, safe and affordable housing, and refugee resettlement. Adam has spent the last 8 years focused on youth substance use prevention, which included leading a county-wide coalition effort to develop and implement environmental strategies designed to address shared risk and protective factors surrounding northern Colorado communities. Most recently, Adam served as a screening, brief intervention, and referral to treatment practice facilitator and trainer, supporting health and behavioral health entities with implementing the best practices of early intervention approaches. Adam lives in Colorado with his wife and 2 boys and appreciates all that the mountains provide as far as outdoor activities, scenery, and serenity. Finally, one more reminder that we will be holding all questions until the end of Adam's presentation. We will also take a short 5-minute break halfway through his presentation. And now I will turn it over to Adam.
Great, thank you so much for that, MK, and very grateful to be with you all today and sort of sharing this topic with you. So we'll get started right away. So, these are sort of it's going to be like some context a little bit around, what SBIRT is if you're not familiar, and then again, really getting into the nitty gritty around tools of the trade or screening tools that are made for the adolescent population. So bear with me here. All right, so you should know that the content, the curriculum of this training has been developed by the Adolescent SBIRT project in conjunction with NORC out of the University of Chicago. And that's all been funded and supported by the Conrad Hilton Foundation. So that's where so much of this work has come from and has come from for quite a while. NORC having a pretty robust expertise in training and technical assistance around this topic of SBIRT generally, but also adolescent SBIRT. And so further, if you all haven't checked out this resource, I really encourage you to do so. But so much of the content today will be gleaned from the Adolescent SBIRT Learner's Guide that was developed by NORC out of the University of Chicago. So a great resource. There's other resources throughout the training today. I'm gonna sort of throw out some different links. Again, this is obviously recorded, and you'll have the PowerPoint that you can use and glean as far as where screening in this case falls within the SBIRT process, and some other contextual resources around this topic. Okay. So our learning objectives today will be first to demonstrate how to administer, score, and interpret validated alcohol and other substance use screening tools for adolescents and transitional age youth to determine level of risk. And we're going to spend the girth of our time today on that. When we talk about adolescents and transitional age youth, we're really looking at, about an 11 to almost 25 age range accompanies those adolescent transitional age youth. And the tools that we're going to talk about, sort of like cast nets and sort of different portions of that continuum of age. And we'll talk a little bit about that. Describe the differences and similarities between various screening tools for adolescent substance use. There's a lot out there. We're not going to go through all of them today. We only got a couple hours, but we're going to look through the gold standards, or the ones that are used the most. And then identify and gain access to free materials and resources available to support professional training on adolescent expert screening, brief intervention, referral to treatment. Again, those will be sort of seated throughout our training today. All right, so let's go right into this topic. So to do some level setting and sort of like create a little bit of a foundation first and foremost is that at-risk substance use can be effectively managed and addressed if the presence and the patterns are identified early. And this is sort of the fundamental where the rubber hits the road of the evidence-based approach of SBIRT, is that we're attempting to screen, to identify risk early on, and especially when we're talking about adolescents, when we can identify that early and address that early, partner with the young person early, we just have better outcomes. And I think, you know, so much of you all's work, you know, probably sort of acknowledges that when we can create those partnerships early, we have better outcomes later on. One of the biggest obstacles to effective screening and intervention is the failure to administer a validated screening tool that guides appropriate levels of intervention. And what levels of intervention we sort of mean here are like from prevention messages to non-users, which sometimes gets left out of the equation altogether, is that, you know, the paradigm of that we need a positive screen in order to engage the patient isn't always necessarily the case. When we have a negative screen, it's an ideal opportunity to operationalize prevention messages, right? To support the choice that the young person is making, consciously or unconsciously, to not use, right? And then to offer, you know, brief advice with those that maybe are not quite at a DSM-5 diagnostic place of a substance use disorder, but when criteria sort of lead that place, it really then connecting them to services for further assessment and perhaps treatment if they're ready and willing to do so. So today's presentation, you'll learn how to introduce that topic, talk about it. We'll have some scripts today that are just samples. And then really, again, like what are the nitty gritty behind some of these best practice tools. So again, around this topic, I think it's important to sort of create this sort of understanding on really like the prevalence of screening. You know, SBIRT's been around for quite a while, and it's been funded and seeded from SAMHSA for several decades now. But, you know, we still have a long way to go as far as the best practices of screening and engaging young people around their substance use. So what you see before you is a slide, a relatively new study by the NORC team, the NORC Adolescent SBIRT team in 2023 that surveyed health professionals and pediatric and family providers, and finding very small or low percentages of those routinely screening adolescent patients around, in this case, their alcohol use. So you see there 33 and 43% respectively for pediatricians, and 14 and 27% for family practitioners, and even fewer for like that lower age group, you know, that middle school 11 to 14 age range as well. Other studies that have been out there have, like, you know, percentages somewhere between 50 and 86. Ultimately, the takeaway here, there's a large variation. There's a lot of, you know, there's a lot of reasons for that, which we'll discuss here in a little bit, of why maybe the screening rates and screening young people and engaging them on this conversation still has not taken hold as far as a standard of care. So moreover, fewer physicians report using validated screening tools and relied on clinical impressions. In fact, pediatric providers typically use general health assessments rather than standardized screening tools. And again, there's reasons for this likely. You know, and clinical judgment is always going to be part of the equation when we're assessing a young person's sort of risk. And that's really important. You have wisdom, you have training that you bring to the fore. That's very important to weave into that assessment with a screening tool. However, the validated screening tools, so much that we're going to be talking about today, are really meant to give you a snapshot in time to help you with your clinical judgment. General health assessments will give you contextual knowledge around a whole range of different factors, but not necessarily like some validated ways of asking questions and finding that information. And when we say a validated screening tool, what we mean is a tool that's been rigorously tested for psychometric reliability, validity, and specificity, right? These are just some of the barriers and just some of the things that we know around screening generally in healthcare. And gosh, there's a lot of screening tools out there, and we're not gonna go through all of these. So if you're looking at this list and you're like, oh, are we really gonna try to get through all these today? Nope, we won't. We're gonna talk about 5 different tools today or so. But the bottom line with this tool is that there's a lot out there, and they're usually publicly available in the public domain. There's just lots of different, tools out there for adolescents, for adults, for different substances, different timeframes, different settings. And that's, sort of what we're going to talk about a little bit about today is that what are some of the differences between these tools and what's the utility of them, from an implementation point of view, right? One thing I'll say, and you'll probably hear me say throughout this training, is that if you're sort of scratching your head, maybe you're already like using a tool and maybe it's not exactly what you need or want as far as a care team, or you're like, we haven't even started, we don't screen our patients, within our respective workflow, and we need to just get started. These are implementation specific sort of questions, and they're important. We're not going to probably get to a ton of that today until the end, where you can ask some implementation specific questions. But, the expert NORC team, which we have some contact information, and my contact information will be part of this, is available to you, for further questions after that. So the takeaway here, there's lots of screeners out there. Okay, so it's important also to like sort of conceptualize and establish what do we even mean by risk, right? And there's different ways and different organizations that have done that. So what you see before you here is really conceptualizing, in this case, alcohol risk, right? So the National Institutes on Alcohol Abuse and Alcoholism, or NIAAA, sort of uses this sort of metric to conceptualize alcohol risk. And why is that important? Because often these metrics, or like this metrics of risks, are superimposed and contained within the screening tool themselves, right? So just to help you better understand, again, conceptualizing what the risk level is, therefore and thereby helping you as the practitioner sort of know what to do next, essentially. So you can see here, really the NIAAA numbers, sort of taking this X and Y axis of the number of days of drinking in the past year and the age of the individual. And you can sort of see that sort of pictorial, the visual on the bottom right-hand side of the screen. It would likely not surprise you that the younger a person is, and the more that they would drink in a concept of time, in this case, throughout a year's point, would be at the highest risk, right? And you can just see again how those sort of different levels striate in the graph below. The NIAAA conception of risk isn't the only one. One of the actually the screeners, the tools we're going to be talking about today that we'll go in depth in, is called the CRAFFT. The CRAFFT has been rigorously tested. It's sort of a catch-all for multiple substances, not just alcohol, when we're assessing youth risk. But really, has these sort of different striations of low risk, medium risk, and high risk based on sort of their scoring, right? Again, they assess adolescent use through a 12-month period, or 12-month window as well. But when it's low risk, their qualifiers are they're maybe not engaging in use in many different ways, but may have not ridden in a car. So part of the CRAFFT, which we'll talk about here in a little bit as well, is that it assesses really riding with someone who is maybe impaired or driving impaired, because we know that that is one of the top 3 causes, or in the top 3 causes of mortality or morbidity for young people nationwide. So it's asked about that. Medium risk is really, someone you maybe is, had some instances of that, driving impaired, reports some substance use. So we're going to want to like engage the young person, on that use at some point. And high risk is 2 or more in the CRAFFT. And this will make a lot more sense when we go through it. But the fundamental takeaway here is each tool has sort of their risk striation that can help, again, sort of dictate what you need to do next. Okay, especially when it comes to, when we're assessing alcohol risk, we need to also to define what is one drink. And this may look familiar to you, this pictorial, but these are what's called standard drink sizes or standard drink amounts. And these are established often through, research throughout the years as well. Why is this important to share, right? So because it's important to share, firstly, because when you engage a patient, an adolescent patient around their, in this case, an alcohol use, we're going to want to be able to like sort of clarify for the patient what is one drink. And so as to get a better idea of what they're reporting, right? Because it's a screening tool, the screening tools we're going to share with you today don't do that. They don't break out, so this is what a standard drink is. How many drinks of these are you drinking per year or per week, whatnot. So what you see before you are those sort of standard drinks. So you might have the Yelp bubble above your head. Well, that's great. But is like the young person going to be drinking like 12 ounces of beer or a cooler? Are they going to be drinking, exactly 1.5 ounces of spirits? And that's exactly why we sort of share it, right? Because we want to try to get an idea really of what that drinking behavior is, for our young person after a screening tool gives us a little bit of insight, right? I have a good example that, I live here in Colorado. I live in Fort Collins. You may know that it's the place of the home of Odell's Brewery. There's like a brewery around basically every corner here in Fort Collins. And I can walk down to like the neighborhood brewery here just down the street, and I can go in and I can find probably, 3, 4 beers on their menu that has an alcohol content way above that 5%, 8, 9, 10% alcohol, depending on the drink. And then just really more of a case in point is that we need to understand the context, the types of drinks that, our young person, our young patient client is engaging in. And because what we do know, especially around youth drinking, is that youth tend to binge drink. And so especially understanding like the amounts of alcohol a young person is engaging in is important. This is just sort of another slide that sort of underscores that sort of same piece. Basically what this shows is just like how this sort of parses out. And I think the most relevant column within this pictorial is like the standard equivalent drinks, right? What you just saw before, you had the standard drink, the beer, the 12 ounces, it being one, it is like an equivalent of itself. But then you just see how like different amounts then sort of change that. Especially, when it comes to like, spirits or hard liquor, really what that looks like. I would just say too, if you're like, well, hey, this would be really handy. It'd be really handy to have something like this, or like the previous slide. It would be really handy to have that when I'm talking with my young person, my youth patient. There's resources for that, and they are also contained within this email. So at NIAAA, for instance, you could go onto their website and download some of these visuals as well. So again, if you need any sort of technical assistance around that, we'll have contact information at the end of the training today. So asking about substance use, it may be more efficient for practitioners to use a tool that screens for multiple substances. And again, we're going to talk about different tools today that, cast sometimes a wide net around different substances and sometimes have very focusing on one substance or two substances. And we'll talk about that. And that's, again, a deferral to sort of you and your context and what your experience is as a professional, as a care team, and with your respective workflow and your patient population. There can be a whole range of reasons why you may want to focus on, just opioid use or just cannabis use. But there may be, there's lots of reasons for casting a wider net and understanding use in a more broad pattern. Because one of the things that we know is that young people generally are engaging in what is called the big three: alcohol, tobacco, or cannabis. So a lot of the tools that we'll review today sort of cast a net over sort of like those big three and others as well. Regardless of the tool, asking about substance use can be difficult. And, young people may not want to disclose their use. This is maybe like, of course, this is like an obvious one. And we're going to talk about confidentiality here in a little bit. And also some motivational interviewing as well. So just like some scripts that you can use motivational interviewing. You all may know that the ESPER process, especially the brief intervention piece, is really undergirded by motivational interviewing skills, right? And really the whole point of so much of using motivational interviewing is empowering and creating conditions of safety around this topic and this conversation, which is like extremely valid and important for talking with a young person, right? So we'll hopefully address some of those issues, later on. And successful screening can be enhanced by memorizing the tools and practicing those conversation skills. Of course, if you have it within your workflow, it's part of your EHR, for instance, it becomes probably just part and parcel that like how to ask the questions, know how to administer it, know how to talk about it. One thing that we do know as a best practice is that, if ever we're like, administering, we'll talk more about administration in a little bit. If we're administering a tool or questions, we want to administer the questions exactly as they're worded and without any variation of our own wording, for instance. We'll talk about that in a little bit, but ultimately underscoring just being familiar with the content of a screening tool that you're using. Whatever the tool and method of administration, introducing the conversation about substance use is a good skill, and it's important to practice. You probably have tons of practice in this, talking about substance use, like so many other type of behavioral health concerns, can be just sort of, there's just a lot of stigma around it. And we know that stigma is a main reason why both young people and adults don't talk about it and don't access care. Really practicing the skills around talking about it is important. And the literature suggests that self-administered screening, whether that's like on a computer, electronically, by paper, is often preferred. And it makes sense. And, that's not just for adolescents, but for adults as well. And it probably makes sense, with the privacy of answering a questionnaire or a screening tool on your own. You're just more likely to get more accurate results. And that's what we're hoping for as well. So I mentioned we're going to present some scripts through here, and these are just like sample scripts. These are just things that just giving some ideas to sort of introduce this topic. There's 119 of you all on there. You may or may not be the person that would introduce this topic, but nonetheless, hopefully this gives you a little context. Even working with people in your care team of how this might roll out, for instance. So how you discuss substance use adolescents it's important, right? And it's important to create that safety around the topic. As a sample script, this is something you could say. And in order to help you get the correct services, I would like to ask you some questions about your health that I ask all my patients or clients. These questions will help me to get to know you and provide you with the services you need. Is that okay? Some things I want to call out here briefly is that, when we say something like, this is something I ask all my patients or clients, we're norming that this is a standard something, it can be, maybe a conscious or unconscious belief within that, young person, if they're being asked, if they haven't been asked, before within, a respective setting around their substance use, that they're being singled out. And of course, that's working against what we want if we're wanting to create safety around this conversation with the young people. So ideally, there's a policy, in place within your respective work setting where there is the screening is a standard sort of procedure for all wellness visits or certain encounter types within your workspace. So you can standardize that. And so there's no bias, for instance, in the administration of the screening. And that's very important, is that those protocols, the frequency of screening is determined early and applied universally, and important to say. Lastly, I'd say, and you see at the end of the script, is it okay? So we're asking a question at there and we're asking permission. This may seem contradictory in some ways, but when we, from a motivational interviewing point of view, when we ask permission, we're validating something that already exists, and ultimately that the young person is going to guide this process, regardless, whether they want to take the screening, whether they want to have a conversation about their substance use at all, right? So when we validate that by asking permission, we're like supporting autonomy. And that's really important. That's something that's borne out in research, both with motivational interviewing and talking about substance use generally, is that when we can really support the autonomy of the young person, it's likely going to be a better outcome as far as talking about the conversation around substance use. And just further along that script, as a way to help me get to know you, I would like to ask you some questions that I ask all my patients or clients. Is that okay? Again, just an alternative script. Okay, this is just again, a sort of a continuation along that script. If I add some questions sort of pushes back, and you all who work with adolescent patients probably have experienced, something like that, it's probably anticipated. You can respond maybe like this. This is, again, just a sample. I ask everyone about their alcohol use, their use of alcohol, tobacco, marijuana, opioids, and other substances. It helps me better understand your concerns and the things that may come up in any work that we do together. The information you tell me is confidential. I will not disclose your answers to your parent, right? So we're calling out here in some ways some different things. Again, like the norm that we're talking about this, like this is not just singling you out. This is a standard procedure. In addition, we're calling out that, this is a confidential conversation, and we're going to talk about sort of what, again, constitutes confidentiality. But again, we know through surveying and research as well that when we can say confidential, when we have a confidential space, and that is a place that's protected and there's policies around that the young person will likely feel more safe to talk about that. If a young person, if you have the yelp above your head, if like, nope, I still don't want to do this, I don't want to do this screening, I don't want to talk about this, we can't force it down their throat and a young person's throat. We can't sort of force this to happen. And we need to obviously have policies, procedures that sort of, move along to a different sort of place within our visit with the young person. Ultimately, they have the power to say if they don't want to fill out a screening. But ideally, by using motivational interviewing, using sort of a standardized universal practice of screening, it becomes easier in starting to erode that stigma. So if an adolescent consents, sample script, I say, now that I'm going to ask you some questions about the various substances you've used in the last year. So we talked about confidentiality. I'd sort of mentioned it just a moment ago, but research has shown that adolescents who are aware of confidentiality are more willing to seek healthcare compared to peers that don't have that same awareness, and that probably makes sense. Fundamentally, we're not going to get into so much in depth, but you probably have these, and confidentiality is different from state to state. But really, how does confidentiality become operationalized within your workflow is an important piece, right? Do you have, and we'll talk about it here in a little bit, but do you have time for where the patient who is a minor, maybe that has time, you have time with them just alone, and the parent and or guardian knows that there's just going to be a time where it's going to be talking with the practitioner yourself in a confidential space. How to sort of norm that within policies, procedures, how to norm that within, the exam room, things like this. Again, state laws govern minor patient rights and confidentiality of information shared with providers around substance use. And for the purposes of this training day with you all in Florida, this is one you're probably familiar with, but that statute that's noted below, since a minor acting alone has the legal capacity to voluntarily apply for and obtain substance abuse treatment, any written consent for disclosure may be given only by the minor. So again, things you probably already know and practice. Ideally, you should explain the full confidentiality policy regarding the disclosure of sensitive issues directly to the adolescent before the screening, ideally, right? Again, whether that's a policy or procedure that's written or in just sort of being creative in some ways of what that delivery might be. When I say being creative, maybe your check-in process is through a patient portal, and you have the ability to load a video about confidentiality, things like this. But ultimately, providing sort of that message up front is important. And of course, if the adolescent is willing, it can be helpful to explain the confidentiality policy with the parent or the guardian at the time. That's an ideal situation when we can trust, and support the self-efficacy of the young person to engage their parent or guardian when the safety is there. Because, ideally, especially around things like, if a young person is going to be accessing treatment, if they're in such a place, having an ally that is a parent or a guardian, caring adult is very important. So conveying confidentiality, this is again a sample script. You all are probably quite proficient at these types of things, but again, just an example. Everything you tell me will be confidential unless I hear that you're harming yourself or someone else is hurting you. I will keep our conversation about your substance use between us unless you agree to include your parents. Do you have any questions for me about confidentiality and its limits? So again, we're calling out here some very sort of mandatory reporting basics, right? Of course, keep things confidential unless, of course, there's a threat of safety around what you tell me, right? So again, just a sample script here. Another script that you could, again, sample. Thank you for completing the form and for your honesty on it. I'd like to tell you about our confidentiality policy. I'll keep the details of what we discussed today confidential, which means I won't share anything with your parents. The limit of confidentiality is safety. So if you tell me something that makes me think that you are at risk of hurting yourself, hurting someone else, or someone is hurting or abusing you, I would have to share that information with the proper officials to make sure everyone is kept safe. Do you have any questions about how that works? So again, probably not an unfamiliar topic to you all, but just again, some sample scripts that are part of that. The bottom line on conveying confidentiality, I mentioned some of this before, but these are some of the steps that can be taken to ensuring confidentiality. Establishing a private time for screening and discussing results. So I sort of mentioned that, whatever that looks like in your workflow, I think is really important. And if you're working with young people, it likely already exists. But to make a carve out for talking about screening results and engaging the young patient in a private space. Keeping follow-up visits confidential. This one can be, difficult at times. If you have a minor that doesn't have their own transportation or whatnot, how do you sort of follow up? That could be done by phone if a young person has their phone, has a phone. But really, the ideal sort of the gold standard would be, being able to follow up with a young person around their use in a confidential way. Talking about referrals, again, if a young person is sort of in this place where they're willing and willing to sort of accept some additional referrals for additional services or assessment, to sort of really talk them through what that looks like, who the people are on the other end, how you can be a help and a liaison within that, how you can sort of ensure that confidentiality is portable, or at least informing the young person of what the policies are to a referring agency if you are referring to another agency. Discussing any procedures that may break confidentiality inadvertently, and clarifying risks of releasing medical records. Okay, now we're going to sort of move into screening administration. And we sort of mentioned it earlier, but the gold standard, the ideal standard is that a screening can be self-administered. But there might be instances where that is not practical or you're not able to do that. I used to work with a pediatric office here where they would administer, and they use the CRAFFT. We'll talk about the CRAFFT here in a little bit, but they administered the first 4 questions of the CRAFFT in a very sort of traditional waiting room style in sort of a paper form. And once, the MA, the medical assistant, took that information, put it into the respective EHR. The provider then asked, based whether it was indicated to ask the additional questions, asked them in an interview style. That's how it worked within their workflow, and it was effective, right? So screenings can be verbally administered. It can be like written, on a hard copy form. Again, this is an implementation specific sort of piece where, again, if you're looking to implement a screening tool and need some assistance around what that looks like in your workflow, do reach out. So I'd mentioned this, again, like it really depends on your workflow. Just gave an example of like self-administered sort of screening in a waiting room prior to the practitioner, engaging them. It's important to inform the parent and the caregiver that the adolescent should complete the form on their own. Again, this would be just sort of like a policy procedure that would be established or like early on or just already established. And the practitioner would then review any sort of responses with the young person. So this is an important one, right? It's just that, we can, take the screening tool and sort of get it like the level of sort of striation of risk and sort of what we do next. But just like, I'd given the example of with alcohol and being able to like take some time to clarify, for instance, like what one drink is and what the drinking sort of pattern is for a young person, you're going to want to review results with the patient, with the youth patient. And that probably makes sense too on some other levels, there's often, sort of there can be this sort of bridge between the young person or a patient filling out a screening tool. And then once you start reviewing it with them, maybe those answers change a little bit, right? That there's maybe a little bit more comfort or maybe it's just like, I'm being a little bit more honest, about my use now. So it's important to review use within those questions as well. Adolescents may feel more comfortable and provide more accurate responses self-administered. We sort of talked about that. And electronic screening with privacy screens may be ideal. There's a lot of different sort of ways to sort of operationalize screening tools. Some of the screening tools we'll talk about, there's apps that are out there. Again, so much, there's electronic, patient portals, kiosks, tablets, a whole range of different things. You may use and employ, many of these different administration techniques. But ideally, again, the fundamental thing, self-administration is important. If it can be done, that privacy helps with the accuracy of the self-report. When an adolescent is responding to questions in a language other than English, self-administered again may be best, of course, positing there that, a screening tool has been, electronically translated and it exists within an e form. So that probably makes sense. I would say, in this bottom bullet here, if there is like a component where based on there's like a lack of literacy or whatnot, like as far as a self-administration piece, then it's completely, of course, appropriate to deliver a screening by way of like a verbal sort of interview style. And often that's like the best practice for like, maybe a young person or a person that's not able to like read a screening tool and answer it appropriately. So just for what it's worth, that's the best practice, for such a patient. Okay, so that was just some basics, some foundational pieces around screening. And now what we're going to do is we're going to transition here into really going into these 4 or 5 tools that we're going to highlight that are sort of the gold standards around screening. So one thing I want to say before we start doing going into like these screening tools is just some language and some differentiation in language, right? So you may hear screening tools or screening and assessment used jointly or like using those like without any difference. And it's important to create some difference in what those two are, right? So a screening tool, and many of the screening tools that we're going to talk about today are sometimes, just a host of questions. When I say a host of questions, they could be 3 to 10 questions or so that give you a snapshot in time, you the practitioner, a snapshot in time around the risk of use. It's not a comprehensive biopsychosocial assessment, right? So that's a difference. That for instance, a biopsychosocial assessment that may take hours to administer we'll take in so much information around the context of behavior around, you know, whatever that patient's context might be, housing, you know, school, social needs, other behavioral needs, physical health needs, a whole range of different biopsychosocial factors. So again, a screening tool, and screening tools are often developed again within a primary care context. As primary care, healthcare settings become more and more integrated, you know, behavioral health professionals have obviously a huge role within that sort of expert process. But I wanted to make sure to sort of create this sort of difference, that you know the difference between a screening tool and an assessment tool. So let's talk about the CRAFFT. The CRAFFT is clearly an acronym. We'll talk about it a little bit here. It'll become a little bit more apparent to you. But the C stands for CAR, the R stands for relax, the A stands for, oh gosh, what does the A stand for? Alone, the two F's for get, family, and T's for trouble. And that'll make more sense here in a little bit. But there's a family of tools, of CRAFFT tools, and it's probably one of the most widely used tools, screening tools for adolescents. And it's been validated for ages 12 to 21. So a pretty good swath. So you get the middle school age bracket, as well as sort of that high school and the beginning of early adulthood as well. We'll talk about it here in a little bit, but you know, the American Academy of Pediatrics, for instance, like very much recommends, you know, start screening that sort of middle school age bracket, you know, that sort of 12, 11, 13, 14 bracket around, you know, substance use risk. So the CRAFFT sort of reflects that as well. And it's designed to ask age-appropriate questions related to alcohol and other substances for a lifetime of substance use disorders simultaneously. So the original CRAFFT was released in 2002. It was developed out of the Center for Adolescent Substance Use Research, or CSER, which has done a ton of research around adolescent screening tools. And again, it's sort of like that's just that gold standard. There's several iterations, and I have a slide here in a little bit that sort of shows what those different iterations of the CRAFFT are, and you may be familiar with them. But the CRAFFT developers, and it probably makes sense, really encourage practitioners, if you're able, to move to like a higher or more updated version, if you're able. So asterisk there, if you're able, and that might not be the case. And when I say that might not be the case, you know, I've worked with, you know, sort of pediatric offices, you know, behavioral health providers, where ultimately the system in some ways dictates what kind of screening tool you can use. When I say the system, like the EHR that can be used. So EHRs may already have screening tools sort of templated within their functionality. And sometimes those templated screening tools aren't the most updated versions, and sometimes they're not the most validated versions. So sometimes you're pigeonholed in that way. But if you're able to, again, go to a more updated version, that probably likely makes sense. The CRAFFT website, you know, the CRAFFT.org is a great website. It doesn't have just the CRAFFT version, it has a ton of other resources, which is another, again, just important thing to share, a great resource to share. And again, most versions have been translated into several different languages. So, you know, really briefly here within the chat box, I'd like to just sort of get an idea of, like, you know, if you're using the CRAFFT. So if you're just in the chat box, if you have the time, if you're with me and you're using the CRAFFT, tell me what kind of CRAFFT version you're using. If you're not using the CRAFFT, you can just say, I don't know, I don't use it, either which way. Just give me an idea. All right. Okay. Got it. All right. I see a few people that have using the most updated version, a lot of people that don't currently use it, a lot of people that don't know. And of course, that's just fine. Again, hopefully the utility of this training today is one that we're all like, gosh, this would be a great screening tool to use in my practice within my respective place within the workflow, and it would be helpful to me. So, you know, if you're in a place to advocate for the use of a screening tool within your workflow, maybe this is helpful. So, all right. All right, bear with me here for a minute. Okay, so, and this will become like a little bit more apparent to you as well, but the updates to the CRAFFT, let me just tell you what those are. So every CRAFFT looks sort of like very similarly. It has a part A and a part B, and the most recent version has a part C, but fundamentally every version has a part A and a part B. The part A is what has changed subtly throughout the years. And when I say subtly, I'll sort of describe that here in a little bit. But part A ultimately determines like the use sort of pattern of the young person, both marijuana, alcohol, other substances within a 12-month period, right? Part B asks more about like the adolescent's experiences with alcohol and substances. And that's important, the part B that's I think sort of like makes the CRAFFT unique in a lot of ways, and it helps you as the practitioner get a little more idea of like how the substances are affecting, if at all, the adolescent patient's life, right? And part C, again, is something that's been added recently to really more catch nicotine or tobacco dependency and risk and harm. So those are the parts of the respective parts of the CRAFFT. Just sort of further along those lines, I had mentioned the subtle changes to part A, which will again make more sense to you once you see it. I'll share it with you here in just a little bit. But ultimately, in the past, some of the older versions of the CRAFFT would ask about really like in a yes or no way of whether like the young person has used, you know, X substance in the last 12 months, this substance in the last 12 months. And, you know, that may make sense is that, you know, there's just not a lot of maybe specificity around that. And so the later versions of the CRAFFT ask more of like estimating the days, and you'll see that here in a little bit. Part A also has included, you know, a question specifically around tobacco or nicotine. So the most recent versions, in this case, like the 2.1 HONK. So the HONK, just so you know, is an acronym, the Hooked on Nicotine Checklist. So that's what the HONK means. But ultimately sort of assessing more comprehensively nicotine and tobacco dependence risk and harm. And again, I just mentioned part C is really sort of the complete HONK checklist. This will make sense to you ideally here in just a minute. So what I'm going to do is I'm just going to go through these parts of this tool and hopefully provide some insight of how you would use it. Right. So like I said, so this is like the newest version of the CRAFFT. This is the CRAFFT N2.1 HONK. So we're going to go through it. Right. So again, it's assessing through a 12-month period. So this first question is, do you drink a few sips of wine, beer, or any other drink containing alcohol? Put a 0 if no days, but then just having the young person estimate their amount of days in a year, right? To give you sort of an idea of frequency. Same thing with cannabis. Any use of any cannabis, marijuana, weed oil, again, it sort of spells out all these sort of different methods or types of products. And that can be helpful with the CRAFFT because, you know, depending on who you're canvassing with the screening tool, they may not necessarily know the connection between certain things such as like K2 and whether that's, you know, part of cannabis or like a cannabis product. Anything else that gets you high, this sort of the catch-all for illegal drugs, pills, over-the-counter medications, things like that. Same scoring piece, you know, a 0 if none, and then estimating the days. And then number 4 here, any use of a vaping device containing nicotine and or flavors. They give examples, e-cigarettes, pod devices, Juul, things like this. Again, the fundamental scoring of this is estimating the days. So what would you do after that? So how would you know, the young person, you know, has filled out these 4 questions, however you might administer it. If the adolescent reports any use at all in those previous 4 questions, The rest of the CRAFFT, the 6 remaining questions, which we'll talk about here in a little bit, should be triggered, right? If the adolescent answers 0 to all of those questions before, you still ask only one question in part A, and that's the car question. You'll see that here in a little bit. And the reason we do that, again, is like something I mentioned before, that the vehicular accidents are, like, again, a top 3 cause of death and morbidity for young people. So we ask that regardless of whether those first 4 questions are positive or not. And again, if an adolescent reports using a vaping device, and that question 4 that I just showed, that would trigger the 10 questions of Part C, or what's called the honk. All right, so these are the remaining Part B questions, right? And they're structured differently. And hopefully you can see how they might, especially as a practitioner, give you some valuable information when you engage the patient, right? So again, the CRAFFT acronym is there. Have you ever ridden in a car or driven with someone, including yourself, who was high or had been using alcohol or drugs, right? So again, this is one that is asked regardless of whether those previous 4 questions were positive or not, to give you that information. And then the rest, sort of go along, along with the acronym again. Do you ever use alcohol or drugs to relax? Do you ever use alcohol or drugs while you're by yourself or alone? Do you ever forget things when you're using? Do your family or friends ever tell you you need to cut down or stop? Have you ever gotten in trouble? So a yes and a no answer. There's no estimation, of course, in this way. It's just a yes or a no. Again, Part C is when you would trigger Part C only if, like, the young person scored positive on that question 4 around tobacco or nicotine. If they estimate, like, yes, even I used 1 day in the last year, you would sort of administer the Part C questions or the honk. And again, these questions are really, like, I'm not going to read through each of them for you. You can look through each one of these questions, but are meant to really, is a response, of course, I think, to the prevalence of vaping over, several years now throughout the country as a method of use of tobacco and nicotine. But really, helps assess that sort of landscape for a young person. And again, a yes and no toggle back and forth. So how do you score and interpret that, right? So the questions in Part A are not scored, but instead indicate just whether Part B is asked. And I'd sort of that's what you would do. That's how you'd mention it. Any yes answer for any question in Part B gets a 1 point, and any no question gets a 0 point. And then you would tally the points in Part B to obtain a final score, right? And these will be the ranges. And this is something that we shared earlier as far as, sort of the risk range. So a score of 0 to 1 can indicate that the substance use risk of substance use disorder, SUD, is low, right? And this might be just engaging the young person on, just some advice, just understanding a little bit more about the use. A score or 2 or more can indicate a more significant problem may exist, and a brief intervention is indicated. Again, within the SBIRT process, this brief intervention is the intentional conversation we have with the young person about their substance use. That can be in another webinar if you'd like, but we're just going to be focusing, of course, on screening today. The 2+ cutoff score is not a hard and fast rule. And this will be something I think I want to underscore within all of this training today around the use of training schools or the use of these tools, is that your clinical judgment is always important. You may have information from maybe a general health assessment. Maybe you have rapport with that patient. You already know that patient's sort of, narrative and their story and sort of what's happening around them. Maybe is that contributing to their substance use. And, just maybe the score doesn't seem right. You maybe have a 2, maybe it's a 1, but you feel like you have a sense within your clinical sort of disposition that you need to follow up and understand a little bit more. So that's what we mean, like this hard and fast rule. Again, also trust your clinical judgment in relation to the information that's being given to you. And a positive response to any question in Part C signals a loss of autonomy and an onset of a tobacco dependence as far as the HONC, the hooked on nicotine checklist. Okay, so that's the CRAFFT. Again, one of the most widely used tools. And now we're going to transition to another tool, what's called the AUDIT-C and the audit as well. But before we do that, I think this is a good time to stop and take a quick break. So MK, I think we can come back, at 12:05. Again, feel free to use the bathroom, grab a snack, and we'll resume at 12:05. Okay, hopefully everyone's back and we'll resume going through some additional tools now. So I mentioned the AUDIT-C and the audit. We'll go through those now. So the audit stands for the Alcohol Use Disorders Identification Test. And it's validated for young adults and those over age 18, and we'll talk a little bit more about that. The difference here is that the audit really focuses on alcohol, right, by its name. So it's different in that way than the CRAFFT that we just reviewed, is that, you know, if you're in a care setting where, you know, ultimately, you know, there's incentive to perhaps, or there's just that, you know, patient population, that's something that you want to catch all or like want to focus on when it comes to alcohol, the audit may be a good choice. It's one of the most widely used tools when it comes to evaluating alcohol risk. It was developed by the World Health Organization quite a while ago. It includes 10 items, and we'll sort of go through that here. When it says here sort of that audit and the AUDIT-C, they're sort of one in the same in some way. The C stands for consumption, and I'll sort of show how they sort of like work together ultimately. Like I just said, you know, the first 3 questions of the audit, which I'll present to you here in a minute, really stand for, again, consumption and assess consumption. They take less than 1 minute to administer. And often can be used in some ways, like you probably are getting a sense, maybe you're getting a sense that like these screening tools have like some initial questions, you know, a few, 1, 2, 3, 4 questions that like sort of, you know, based on risk triation, then indicate whether you should ask like additional question. And the audit and the AUDIT-C is the same way. It's going to have 3 questions or so that you ask, and ultimately, if they're not positive, you wouldn't ask the remaining questions. If they are positive, you do ask the remaining questions. So that's a similarity, a theme, you know, that you'll find in many of the different tools. Yeah, it suggests that, you know, when an adolescent reports any use to question 1, and we'll talk about that, the full audit should be administered. Yeah, the score of the AUDIT-C is used to determine whether the remaining 7 questions of the audit should be administered. I just sort of mentioned that. So there's some links here to important information, just like if you want to download, take a look, a little bit more about the audit. An important, you know, takeaway from this slide is that, you know, the World Health Organization developed the audit, you know, and I don't remember exactly the duration of how long ago, but they developed it in really a way like assessing alcohol risk, you know, that was more global, of course, in its assessment. And it may not be a surprise to you, but, you know, different countries assess alcohol or standard drinks or how many drinks differently than the US, right? So when you're searching, or if you're interested in looking at the audit, you want to review it more, whether that would work for you, your care team, or your patient population, you would want to search, for instance, or look for the US audit, because it's important for that, because the drink levels, or the drink sort of baseline of assessing sort of alcohol risk is geared to the US drink guidelines and that low risk drink guidelines, which is established by the NIAAA, an entity that's been mentioned a few times already in this presentation. But those drink limits are, for instance, for men, it's no more than 4 per day and 14 per week. And for women, no more than 3 per day and 7 per week. That's just established, like an established bench line, you know, by the NIAAA. And again, it was reflected within how the audit asks questions around frequency and consumption and use. So just like the CRAFFT, we're going to just like create, you know, just some sample ways of where you can introduce administering the AUDIT-C or the AUDIT-C plus 2. Again, you know, sort of underscoring that self-administering is like an ideal method of administration. But you might say, you know, with your permission, I'm going to ask you some questions about your your use of alcoholic beverages during the past year. Again, asking permission, again, affirms autonomy. And this, you know, is a place, you know, where you can create some, you know, education in some ways around like what alcohol means, you know, maybe using like a visual that we had sort of displayed earlier in this presentation, but refers to any form of alcohol, a drink, and what a standard drink size is. Again, like using a visual aid. additional language you could use. Because alcohol can affect your health and can interfere with certain medications and treatments, it is important we ask you some questions about your use of alcohol. Your answers will remain confidential, so please be honest. Place an X in one box that best describes your answers for each question. And again, that'll make more sense to you here in a moment. So this is the audit, and this is the Audit-C, right? So again, the Audit-C is simply the first 3 questions of the full audit, right? And this is what's gauging consumption. So that first question, how often do you have a drink containing alcohol? And those are your choices that you see in the row that follows. Never, monthly or less, 2 to 4 times per month, 2 to 3 times per week, or 4 or more times per week. And again, they have requisite scoring. You see the number above them, a 0, a 1, a 2, a 3, or a 4, right? So if your young patient answers number 1, never, the score is 0 and you don't have to continue the rest of the questions, right? So a 0 score sort of eliminates the rest of the questions, right? And if you were to administer this to an adult as well, that's the same way, right? But any score, you know, a 1, 2, 3, or 4 on that first question then sort of triggers the rest, right? How many drinks containing alcohol do you have on a typical day of drinking? You see the requisite sort of, you know, numbers there. And number 3, how often do you have 5 for men, 4 or more drinks for women on an occasion? And again, a requisite score there. So again, all of them are scored on that 0 to 4 range of a scale, and you just simply add them up. That's all you would do to sort of see what you need to do next as far as risks. For adolescents 14 to 18, you know, if this was administered, any alcohol use that's indicated in that first question, it's recommended to complete the remainder of the audit, and we'll go through that, the remaining questions here in a little bit. Any young people that are over the age of 18, again, the Audit-C, you know, like I mentioned, that sort of 4 and 3 respective sort of limit indicates a positive or a score of 4 for men and 3 for women, indicates a positive screening. You would again ask, you know, the remaining questions of the audit. So what are those remaining questions? So number 4 is, how often during the last year have you found that you were not able to stop drinking once you had started? Number 5 is, how often during the last year have you failed to do what was normally expected of you because of drinking? And number 6, how often during the last year have you needed a first drink in the morning to get yourself going after a heavy session of drinking? You'll see that, so like 4 through 6, these questions are really sort of assessing dependence, right? And again, the scoring is the same. You can see that ultimately the responses or the frequency is slightly different, but ultimately the scoring again is the same. And then the remaining questions here in this section are assessing harmful use. So how often during the last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been able to remember, not been able to remember the night before because of drinking? Have you or someone else been injured because of your drinking? Has a relative, friend, doctor, or other healthcare worker been concerned about your drinking and suggesting to cut down? So again, assessing harmful use in this way. And so, you know, again, if like those first 3 questions triggered the asking of the remaining questions that we just reviewed, you just add up the scores to all the questions, and the risk ranges are here. So for any, again, like adolescents age 14 to 18 or so, a cutoff score of 2 or so suggests like problematic use, and you'd want to engage in a brief intervention or start addressing that with the young person. So there's some specificity variance within the research around this, but ultimately like that 2 or 3 cutoff is where you want to engage, you know, the patient. And again, positing your clinical judgment is always important. But fundamentally, how does the striation of risk look for that age range? Again, low risk, 0 to 1, moderate risk, perhaps problematic use, potential harms, 2, high risk, possible dependence, 3 or more. How about for your young adults that are older than 18? So the audit score of 8 or more indicates at risk, potentially harmful and hazardous use, right? So it's a little bit different, you know, like based on the age range here in this tool of the audit, right? The younger sort of 14 to 18 have a little bit different of a striation. And then the 18 plus really have like sort of what an adult actually would have as far as their scoring. And you see that risk range on the right-hand side of the screen. Low risk would be a scoring of 0 to 7. Moderate risk 8 to 8 to 19, and this is where you would like if a score fell within this range, you would engage the patient in that way. High risk or possible dependence, that 20 to 40 range. Important to note that a score of 10 is not necessarily better than a score 11. Again, it's how it falls within a range, again, of those risk striations that I mentioned before. And again, like I had mentioned, you know, using your clinical judgment is going to always be important. So we have a sample video of how this the audit could be administered in more of a you know, an interview style, and some of the motivational interviewing sort of techniques that you can hear sort of within the interview style. It's about a 5-minute video, and we're going to play that now. So.
The audit was developed by the World Health Organization as a simple method of screening for excessive drinking and to assist in brief assessment. It provides a framework for intervention to help risky drinkers reduce or cease alcohol consumption and thereby avoid the harmful consequences of their drinking. The audit also helps to identify alcohol dependence and some specific consequences of harmful drinking. It may be administered either as a self-report questionnaire or as an in-person interview. The questionnaire takes less time, is easy to administer, is suitable for computer administration and scoring, and may produce more accurate answers. The interview allows clarification of ambiguous answers, can be administered to clients with poor reading skills, and allows seamless feedback to the client and initiation of brief advice. Each method carries its own advantages and disadvantages that must be weighed in light of time and cost constraints.
So Steve, what brings you in today?
Well, I've been having some problems at work.
Things at work aren't going so well for you. I'm glad you came in to get some extra support. It could really be a great step towards changing things for the better.
Yeah, I guess you could say that.
Well, I'd like to start out by asking you some questions about your alcohol use. We ask all clients standard questions around substances because it can really help us to achieve the best outcomes of coming in for services. Because alcohol can affect many areas of our clients' lives, it's important for us to know how much you usually drink, whether or not you've experienced any negative problems from drinking. It should only take a couple of minutes. Would it be okay to continue?
Well, I guess so, but I don't really have a problem with alcohol.
Okay. I really appreciate you being so open to discussing this with me today. How often do you have a drink containing alcohol?
Well, I don't drink on the days that I work. You know, Fridays and Saturdays, sometimes Sunday too.
Okay, so 2 to 3 times a week. And how many drinks containing alcohol do you have on a typical day when you're drinking?
Not that much. You know, I'll have maybe 4 beers and then a couple of shots. So, I don't know, maybe a total of 6.
Okay, so it sounds like a standard for you might be 6. And how often do you have 4 or more drinks on one occasion? Based on what you've told me so far, it sounds like this is weekly for you. Is that right?
Yeah, I think weekly's fair.
Okay. How often during the last year have you found that you were not able to stop drinking once you started?
Never. I can always stop when I want to. Like I said, I don't have a drinking problem.
Okay. It sounds like you can decide how much to drink and stick with it. I have just a few more questions for you. Thank you so much for sharing this information with me. How often during the last year have you failed to do what was normally expected of you because of drinking?
Well, I called in sick to work one time because I was so hungover. I guess you could consider that failing to do what was expected of me.
Okay. Drinking interfered with your work responsibilities that one time, though it sounds like it's not a regular occurrence for you. How often during the last year have you needed an alcoholic drink in the morning to get yourself going after a heavy drinking session?
Never. I'm not an alcoholic.
Okay, never. Next question is, how often during the last year have you had a feeling of guilt or regret after drinking?
Well, I felt pretty guilty that time that I called in sick. That's just not like me.
Okay. Sounds like being on top of your work responsibilities is important to you. And how often during the last year have you been unable to remember what happened the night before because you'd been drinking?
Oh, never. I don't black out.
Okay. You don't experience blackouts when you drink. Have you or someone else been injured as a result of your drinking?
No, never anything crazy like that. I keep it under control when I drink.
So keeping your drinking under control is important to you. You don't want it to affect your life negatively.
Yeah, that's right.
Okay. One last question for you. Has a friend, relative, doctor, or other health worker ever been concerned or suggested you cut down on your drinking?
Well, my wife got on my case pretty hard that time that I called in sick to work, but I think she was just blowing it out of proportion. I know when it's time to be serious and work and when it's time to let loose and have some fun.
So you like to keep a healthy balance between work and fun.
Yeah, that's right.
When was it last that your wife expressed concern about your drinking?
I'd say that was about a month ago when I called in sick.
Well, thank you so much for sharing all this information with me. It really gives us more information to work with as we address some of your future concerns.
Audit scores of 8 or more are recommended as indicators of hazardous and harmful use, as well as possible alcohol dependence. Scores between 8 and 15 are more appropriate for simple advice focused on the reduction of hazardous drinking. Scores between 16 and 19 suggest brief counseling and continued monitoring. Scores of 20 or above warrant further diagnostic evaluation for alcohol dependence. This client scored 14 on the audit. A brief intervention focused on the reduction of hazardous drinking using simple advice and motivational enhancement techniques is most appropriate.
Okay. Thank you for doing the sort of toggle back and forth, the technical team. So again, just a video sort of demonstrate how the audit can be administered. It's a little bit older, but you saw like the MET probably, those are just motivational enhancement techniques that were sort of being spelled out, reflections, affirmations, whatnot. Again, not sort of part and parcel to our topic today, but part of SBIRT more broadly. So, all right, we will continue on. All right, we're going to now move to just a few more tools to round out for today. And the next one we're going to talk about is screening to brief intervention, or the S2BI tool. So this is, again, is in some ways is a very similar tool as far as assessing multiple substances like the CRAFFT. It's validated for ages 12 to 17 and was developed in Boston by the Boston Children's Hospital. So again, really focusing more on that younger age bracket. It can be administered in interview, self-administered again as well. It should be administered during each visit. The substances screened in an S2BI are categorized in categories including alcohol, marijuana, cocaine, and prescription drugs. The tool identifies adolescents at high risk of a substance use disorder defined by the DSM-5. So administering the S2BI, and this would be one of those similarities, between, the last two tools and the CRAFFT, but it has 3 first questions that sort of indicate or parse out sort of a risk level, and then, based on whether they're positive or negative, to ask remaining questions, right? So the adolescent who answers never to a past year, so again, it's casting a net or a duration of 1 year, similar to both the audit and the CRAFFT. Around alcohol, marijuana, tobacco, nicotine, do not need to respond to the remaining questions. And that's been pretty consistent, with other tools. Adolescents who indicate any use should be asked the remaining 4 questions about the use of other substances. So let's talk about that. First, introduce what a script might sound like. Before administering the questions, you might be able, just as an example, the following questions will ask about your use, if any, around tobacco, alcohol, and other drugs. Please answer every question as best possible. So here are those questions. In the past year, how many times have you used nicotine, tobacco, including cigarettes, e-cigarettes, or vapes? And you see the frequency there. A young person, the patient, can circle never, once or twice, monthly, weekly, or more. Then you have the requisite question for alcohol, and then the requisite question for marijuana. such as vaping, smoking, edibles, something like as such. Again, you know, if your patient answers never to any of those questions, then you do not need to proceed to the remaining questions. But if there is, you know, even like, you know, some continued or once or more monthly, weekly or more use, you would ask these 4 questions, right? Again, canvassing over a past year. Prescription drugs that were not prescribed to use, such as pain medication or Adderall. Excuse me, illegal drugs such as cocaine, ecstasy, or Molly, inhalants such as nitrous oxide, and herbs or synthetic drugs such as Sylvia K2 bath salts. Again, having the young person circle what that frequency best is. So this is the scoring and interpreting of it. Again, if there's never been any use, this is you know, something we talked about at the onset of our training, is that, you know, always when if there's a negative screen, when we say a negative screen, that there's like no reported use or very limited or a low risk level of use, that's an opportunity to affirm and support the choices of that young person. That's primary prevention, and it's very powerful to do so. So providing that positive reinforcement is important. That once or twice use, there's no substance use disorder risk, but you might provide that sort of brief advice, maybe some education around the use, and that ultimately choosing not to use is the best choice. Monthly use indicates more of a mild, moderate risk of a substance use disorder. And this might indicate conducting further assessment. When we say further assessment, you know, whether yourself, a part of your care team, referring out, but more assessment as far as biopsychosocial factors related to the substance use. Providing brief motivational interviewing intervention, so assessing the problems, advising to quit, making a plan with the patient, and advising to reduce risky behaviors as well. And then of course, weekly or more, that's the highest level of risk. Severe substance use disorder risk, similar to connecting further assessment, trying to connect that young person to the appropriate level of care. Okay, we're close to finishing up, you know, rounding out the tools. We're going to now pivot to what's called the Cannabis Use Disorders Identification Test Revised, or the CUDIT. So similarly, to the audit, which we talked about 2 tools ago, the CUDIT is just focusing on cannabis. That's it, right? And it's validated for really more of that 18 and above age range. And it includes an 8 questions or so that we'll go through here. Again, it's linked here as well if you want to learn a little bit more about it. So the CUDIT is sort of set up a little bit differently. It's simply 8 questions that are administered after asking, has the patient used cannabis in the past 6 months? So that's a little bit different. You know, the CUDIT is asking around a 6-month window, not a 12-month window, which has been, you know, what the sort of duration has been for the previous tools. So, you know, if obviously if the, you know, the youth patient answers no in this way, then you would not ask the remaining question. If it's a yes, then you're going to ask more about, like, again, the frequency and types of use. How often do you use cannabis? There you see is number 1. And again, you know, you see the frequency, each one of them has a point value that you see there. How many hours were you stoned on a typical day when you were using cannabis? How often during the past 6 months did you find that you were not able to stop using cannabis once you started? How often during the past 6 months did you fail to do what was normally expected of you because of using cannabis? How often in the past 6 months have you devoted a great deal of your time to getting, using, and recovering from cannabis? How often in this 6-month period have you had a problem with memory or concentration? Often do you use cannabis in situations that are physically dangerous or hazardous, driving, operating machinery, etc.? And have you ever thought about cutting down, stopping, or use of cannabis? Again, requisite scoring there. I should say, so like the scoring around the CUDIT, and again, you can find more information there, but a score of 8 or more is an indicator for potentially like a cannabis use disorder, and would indicate a brief intervention, and then using, again, your clinical and judgment to engage the patient. Okay, so those are some of the main tools. I'm just going to hit on a few like some other tools here, some resources, and then we'll probably be finishing up here, in the next, 5 to 10 minutes or so. So just some other screening tools, at the onset, I sort of provide that sort of list. There's a range of other tools that can be accessed through the NIAAA that provide, not just the tools, but like a range of guides, how to use them, different motivational interviewing techniques, along with sort of, again, within the sort of ASPERT pathway. So that's a good one to check out as well. And the American Psychiatric Association offers also a really, a slightly different way, or a tool that's both assessing multiple sort of like mental health factors in relation to the behavioral substance use factors as well, which can be very helpful, if you're not doing that already. One thing that sometimes I think comes up from the field is that, well, hey, as practitioners, we might be conducting multiple types of screening tools to like get more information around depression, anxiety, suicidality, in addition to maybe substance use. And of course, there's cross-cutting things here. The benefit of tools that are offered, for instance, like the APA offers, again, it's assessing both mental health, behavioral health factors for both adolescents, 11 to 17, and younger children as well. So something to check out. These are some things that are similar, just some NIAAA resources around, again, guides around the best practices, some of the things that we've already talked about here today. Just providing some more information around those here. And lastly, there is a quick screen that can be used and employed that is appropriate, more for the 18 or above age range. And that's the NIDA quick screen, which is developed by the National Institute of Drug Abuse. And it's really, meant to be like something that was really sort of administratively easy to administer. It's only 4 items. It just takes 1 to 2 minutes, but assesses, again, alcohol, tobacco, other prescription drugs. So casting a wide net, but again, for 18 or older. What does that look like? This is what the NIDA quick screen looks like. You may all be familiar with it. You'll see that when it asks about the alcohol, those again are like sort of adult or 18 or older numbers. And again, ultimately asking about in a past year sort of sequence as well. Okay. Well, we are at the end of the formal presentation, and I think this is the ideal time. If you've had questions that have come up in the chat box, whether you've scratched them, down on some scratch paper or whatnot, this would be a time to like bring them up. So I'm happy to attempt to field any questions that you may have. Feel free to put it in the chat box, or MK, if you happen to have any of those, you can direct them to me as well.
Sure, I didn't see any come through, but like you just said, now would be the time for attendees to put a question in the chat. So we can pause for a few minutes if anyone has any questions for Adam before we wrap up.
Thanks, MK.
Well, I'm not seeing any come through, so if it's good with you. Oh, we have one.
Oh, we have one. Is your outlook so that we might refer back to the various assessments as closed? MK, I'll defer to you. I assume it'll be available, so.
Yes, it'll be available, and we can drop it in the chat now. And looks like we have another question from Eva.
Okay, so I see one, let me just here. In the CRAFFT, why does part B score 18 with a 0 to 1 as low risk in SBIRT and not require a brief intervention? Good question. Yeah, so ultimately, if a CRAFFT score is right around, I mean, and then so it's empirically driven, right? So like ultimately, you know, that they're, you know, so empirically driven that when there's a score around that range, that it's not indicative of a substance use disorder and there's like a lower risk range. But again, I think, you know, as, you know, hopefully the slides and I've indicated, you know, if you have information and you want to follow up around some of the questions within again, your clinical judgment lens, like to sort of, engage the patient a little bit more around that risk, that's absolutely part of this purview, right? So, and when it says like, low risk and not require brief intervention, that doesn't necessarily mean like not engaging the patient, right? So the brief intervention, which you may know, but the brief intervention is a structured sort of way to have that conversation around risk. You know, if there's a low risk situation, you might be gleaning more information, using some motivational interviewing techniques, but sort of providing some advice, right? And advice is different, than like a full blown intervention or brief intervention. So part of it's empirically driven just based on the research that's been extensively done with the CRAFFT around what those scores often indicate. But also I would again sort of defer to like, making sure you are employing your clinical judgment as well. Okay. Let's see. All right. Well, thank you for the thank yous. I appreciate that. Any other questions before, let's see. There's another
We
one.
have, it looks like we have two in the chat, one from Pamela. As a matter of practice, if it appears a youth is purposefully blowing off an assignment, would you discontinue or record response and notable? Noted.
Yeah. So yeah, so blowing off, meaning like probably just like not answering it appropriately or just like maybe not accurately, just sort of, yeah. In that situation, that's a good question. Ultimately, that sort of, I think, goes to, really like then being able to sort of follow up with the patient around their questions. Now, if they're blowing it up, I mean, if they're like way overestimating or whatnot, again, fundamentally, I think using your feel, like if the young person is not in a place to have this kind of conversation with whether they're being sarcastic, whatever the reaction might be, and again, like I'm going to really sort of like create, this is not just like I'm not going to have a general response to this, because ultimately, if you know that patient, you have some rapport with that patient and they're having a day, so to speak, then you might be able to sort of like, with some, of your clinical training and your being and your motivational interviewing maybe skill set to like, what's happening today? What's what's going on? Tell me a little bit more. You seem like maybe like something's bothering you today. If that's the case, right? If you don't know the patient, and they're just, they might just be blowing it off. It might be worth, like again, sort of like doubling down on this is a policy that we ask everybody and maybe following up with some of those questions. But ultimately, if the young person is just like not in a place, they're not going to be talking with you about it. Like that's okay. You can, maybe use something like, a script such as, like, hey, it feels like maybe this is not the best time to talk about these, these things today, talk about substance use as well as the screening tool. And that's okay. We can maybe talk about it at a different time and at a different visit. What are some of the things that you would like to focus on today? Sort of just creating some pivot there. It's not avoidance, but at the same time, we don't want to, if the young person's not there to have that conversation, it'll be not productive to keep on sort of like trying to like mine away at it. So thanks, Pamela.
We had another question from Dr. Walker asking if
Okay.
you can explain again from slide 13 what a drink means. And Dr. Walker wants to know how are we to interpret the chart.
Okay, sounds good. I'm gonna roll back to slide 13. Gosh, that's a lot of slides ago. Bear with me here, please. Yeah, so explain 13, what does one drink mean? So this, I mean, this is what is constituted by one drink and how it's defined by multiple, I think the CDC, multiple like organizations here in the US, what is defined as one drink. And this is meant to be simply as a baseline, right? So we don't have these kind of baselines for other substances, right? There's not this kind of pictorial like for cannabis use, for instance, you know, but for alcohol, it can create a baseline when we have that conversation, right? So let's say, you know, you're administering the audit to a patient, right? And, you know, you're conveying to them what one drink is, maybe using a pictorial like this, you know, simply like so they can have an idea about what that sort of constitutes or what qualifies as that one drink. So that's what these different sort of pictures mean. Like, so that, you know, 12 ounces of beer at 5% alcohol is the standard drink. That wine, again, at 5 ounces of 12% alcohol is a standard drink. And so again, like this is really important to like then follow up with the patient around, you know, what that is. So if like, you know, the patient reported like, you know, in the past year, I've maybe had, you know, 50 drinks, you know, let's say they answer that in the CRAFFT screening tool, 50 drinks and they were beer, you know, so you might want to clarify, okay, like, so what you know, again, a standard drink, you know, as far as beer is 12 ounces of beer with like, you know, 5% alcohol. Is that, you know, is that sort of what you've been drinking? Yeah, man, I drink, you know, when I go to a party, I'm drinking a standard Coors Light. I'm drinking a Coors Light. Or no, maybe I'm drinking something else. Maybe I'm drinking, you know, a seltzer that has, you know, more alcohol in it. It's meant to be simply as like sort of like a benchmark that helps you explore the use, in this case, the alcohol consumption use of the patient, and establishing that baseline as what is one drink, and this is what it is. So hopefully that's helpful. Like there's not so much, it's more like creating that baseline of an understanding of one drink so you can reference it both within your own understanding and with the patient, to sort of create that sort of context around consumption and use. Hopefully that's helpful.
Well, that looks like all of the questions that we have today. So I'm going to take back over, run us through a few housekeeping items to finish us off. Thank you so much again, Adam, for running us through all of that.
For sure. Thank you all. I appreciate what you do.
So we've included Adam's contact information so that you may contact him with any further questions. Please note we're going to go through a few items of business before we finish up. In the chat panel, we have put today's survey link, although we're seeing a few comments that it's not working, but don't worry, when the webinar ends, a pop-up will come up on your computer that you can click continue, and then you will be able to fill out the evaluation. Also, we will email out the evaluation to you later today. You must sign into your account to complete the evaluation. If you do not have an account, you can register at no cost, and you may do so by clicking Haven't Registered Yet. You must use the same email address you used when you registered for today's webinar when you set up your profile using FATA's system. This is the only way that we can connect your attendance to your profile. For CEs to be reported to the CE broker, you must provide an accurate Florida Department of Health license, prefix, and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the Professional Information section of your profile. Like I mentioned before, you will have another opportunity to complete the evaluation through a follow-up email later today. Please know that the evaluation will close at the end of the day on Monday, December 16th, 2024. For assistance with account login, account registration, or evaluation, you can fill out a contact us form on our website, or you can email training@floridabha.org. And that we will not email statements of completion. Instead, after we verify attendance and completion of the evaluation, the statement of completion will be posted to the professional development section of your profile on the FADA website within 30 business days. You must have attended the entire webinar and completed the evaluation for a statement of completion. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, visit www.fada.org, navigate to the Resource Center, and click the Training Library as shown on the screen. Thank you again for participating in today's webinar. Thank you again to Adam for his great presentation. Finally, we would like to recognize the Florida Department of Children and Families for funding today's education. Have a great day, and please hold for the evaluation link.